right?
Mm.
And you are on, let's say, hour 10 of just a brutal, entirely understaffed shift.
Yeah, that exhaustion it's bone deep at that point.
Exactly. You are completely exhausted, your feet are aching, the alarms out on the floor just will not stop beeping, and you have this severely confused elderly patient who keeps trying to climb out of their bed.
Right, which is a massive fall risk.
A terrible fall risk.
Yeah.
So out of sheer frustration and honestly just desperation to keep this person safe, you stand in the doorway, you point your finger, you say, if you get out of that bed one more time, I'm going to tie you down.
And that right there is a moment of just pure human exhaustion. It happens every day.
Right, and you didn't touch them. You didn't actually reach for any restraints at all. You just issued a warning.
Yeah.
But legally,
Yeah.
in the eyes of the law, you just committed assault.
You did. You have just crossed a massive legal boundary without laying a single finger on that patient. And the terrifying part is that split-second decision can completely end a career.
That honestly blew my mind when I first learned it. Welcome to the deep dive, everyone. Today, we are basically taking a sledgehammer to the way most of us think about modern medicine.
It really is a paradigm shift.
It is. Because usually when we talk about healthcare, we expect precision. Like engineering. You break your arm, an x-ray shows the jagged line, the doctor sets the bone, and you're done.
We want medicine to be this binary science, broken or not broken, healthy or sick. It is deeply comforting to believe that hospitals operate strictly on objective biology.
But the reality behind the curtain is incredibly murky. And that's our mission today. We're exploring the hidden rulebook of the hospital. We're getting into the absolute trenches of medical ethics and legal liability, using some really fascinating real-world nursing lectures, complete with the slide decks and everything.
It is essentially a survival guide for healthcare workers.
Yeah, and if you are listening to this, whether you work in healthcare yourself, or maybe you're managing care for an aging parent, or you're just someone who occasionally has to sit in a waiting room, understanding this invisible tightrope is going to completely change how you view your next doctor's visit.
It really will.
Because every single person in scrubs walking past you is navigating this crazy minefield where doing what feels like the right thing in their gut might actually get them fired or sued. Or in some absolutely terrifying cases that we will get into later, criminally charged.
It is a staggering amount of pressure. I mean, we're looking at a collision of personal beliefs, federal laws, and these incredibly high-stakes decisions where the correct answer often leaves someone suffering anyway. It requires a total rewiring of how a person operates in the world.
So let's start with that rewiring. Because to even understand the rule book, we have to define the playing field. And that starts with drawing a very hard, incredibly rigid line between two words that I and probably most people just use interchangeably in everyday life: morals and ethics.
Separating those two concepts is the foundational step of becoming a professional in any high-stakes field, but especially in healthcare. So morals are your internal compass.
Okay, internal compass.
Yes, they are private. They are those deeply held personal judgments about behavior that you develop over a lifetime. They are rooted in your upbringing, your culture, your traditions, maybe your religion.
So my morals dictate how I behave when nobody is watching.
Yeah.
If I believe that lying is fundamentally, unequivocally wrong under any circumstance whatsoever, that is my moral stance.
Precisely. That is your internal compass. But ethics. Ethics are the traffic laws.
The traffic laws.
Right. Ethics represent a formal, agreed-upon professional process for making decisions. They dictate what you should or shouldn't do in a given professional situation. And honestly, they do not care about your internal compass.
Okay, let's unpack this, because the clash between the two is where the drama actually happens. Consider an attorney. Right? Morally, as a human being sitting at home, this attorney might believe that lying or withholding the truth is a sin. But ethically, the moment they step into their office, they are bound by the strict code of attorney-client privilege. If their client confesses to something terrible, their professional ethics legally require them to conceal that truth. So the professional traffic laws just completely override the internal compass.
And in a courtroom, that override dictates justice. But in a hospital, that override dictates life and death.
Wow.
Look at how this applies to something like reproductive care from our source material. You might have a healthcare worker who is personally deeply morally opposed to abortion. Their internal compass points firmly in one direction.
Right. And just to pause here really quickly for you listening, we have to explicitly state that we are remaining strictly impartial here. We are not taking a side on the politics of this issue. We are merely reporting the educational scenario provided in the source material to illustrate this clash.
Absolutely. This is purely an educational framework. So If that healthcare worker is employed by a facility that provides that care and a patient is assigned to them, their professional ethics demand that they care for that patient with complete dignity, respect, and clinical excellence.
And just to look at the mechanics of that, it requires a profound level of compartmentalization.
Yeah.
We are looking at a scenario where a professional has to actively suppress their deepest personal convictions just to fulfill a professional duty.
It is an agonizing tension for many people, but the professional obligation is absolute. It demands a concept known in the literature as value neutrality.
Okay, let's unpack value neutrality, because I have to be honest, that sounds almost robotic.
Yeah.
Like you're asking a human being to just turn off their soul before they clock in for their shift.
It does sound sterile when you say it like that, but think about the alternative. The idea isn't that you don't have personal values. That is impossible. You cannot erase a person's humanity. Value neutrality is the active, learned skill of recognizing your own values, acknowledging them, and then deliberately setting them aside to become a non-judgmental advocate for the patient. It's creating this emotional and intellectual firewall so your values don't become a barrier to someone else's legal and medical rights.
Oh, let me try an analogy here to see if I'm tracking this. It's like, okay, it's like choosing to be a strict vegetarian at home because of your profound personal moral beliefs about animal welfare. That is your private compass.
Okay.
But let's say you get a job working as a health inspector, or you're managing a commercial restaurant kitchen. You might personally hate the idea of handling meat, but professionally, you are bound by strict FDA food safety ethics. You have to ensure that the meat reaches the exact internal temperature required by federal regulations to keep the customer safe. Your personal disgust doesn't exempt you from the safety protocols of the job.
That is a highly effective way to frame it. The FDA regulations don't care if you're a vegetarian. They care that the customer doesn't get sick. In healthcare, the stakes are just infinitely higher. And the real danger here is that human values, our internal compasses, are incredibly fragile. They are not fixed monuments.
Yes, the bad apple phenomenon. This part of human psychology from the text is so dark, but so real.
It really is. Think about how a new employee enters a high-stress environment. They usually arrive with their morals completely intact. They are empathetic, they want to do everything by the book, but then they are dropped into a toxic work culture.
Yeah.
They are overworked, undersupported, and crucially, they start observing a bad apple.
Like a veteran nurse or a doctor who just cuts corners. Someone who is callous to patients, who skips safety checks, but who never seems to get caught or punished. In fact, maybe they even get praised because they work really fast.
Exactly. And over the course of, say, 6 months, that idealistic new hire watches this behavior be normalized. The environment begins to literally corrupt their internal compass. Through sheer observation and negative workplace reinforcement, their values shift. And suddenly, they are cutting the exact same corners.
Which is exactly why we can't just rely on healthcare workers being naturally good people. Because what does good even mean on hour 12 of a chaotic shift when everyone around you is acting terribly? You need the traffic laws. You need an external, unyielding framework.
Which that is the baseline, yes, the right to self-determination. But practically, on the floor, autonomy is far more pervasive. It dictates how a provider must perceive a patient's reality.
The example of pain management perfectly illustrates this. If I am the patient, and I press the call button and tell my nurse I am in 10 out of 10 pain. Autonomy means that the nurse has an ethical duty to believe my report of my own symptoms, even if I'm just sitting there quietly scrolling on my phone, not crying or wincing at all.
This is a massive hurdle in clinical practice. The provider might look at you and think, well, my internal judgment tells me this person is drug-seeking, or they are just exaggerating because they look perfectly comfortable. But acting on that personal judgment strips you of your autonomy over your own bodily experience. The ethical pillar demands that the patient is the ultimate authority on their own pain.
And if you violate that, you aren't just being a jerk, you are committing an actual ethical breach, which bleeds right into the next pillar. Non-maleficence, the famous Hippocratic oath, do no harm. But again, we have to redefine harm here, because nobody goes to work at a hospital intending to maliciously hurt someone.
Right. Malice is rarely the issue. Non-maleficence is actually about avoiding the risk of harm. It is a proactive duty.
The call light example from the lecture is what really terrified me here. It is so mundane. Let's say a nurse finishes checking my vitals, hits my water pitcher down, and accidentally leaves the call button on the bedside table instead of clipping it to my pillow.
Yeah.
Just a simple, completely innocent oversight.
Just a momentary lapse in attention.
But what if, 5 minutes after they leave the room, I start having a massive myocardial infarction, a heart attack? I am paralyzed with chest pain, and I physically cannot reach across the gap to the table to press that button.
That innocent oversight has just escalated into a catastrophic failure of non-maleficence. The nurse didn't cause the heart attack, obviously, but by failing to place the call light within reach, they created an environment where the risk of harm was exponentially magnified. They failed to protect you from the risk.
It makes you realize how every tiny movement in a hospital room is loaded with ethical weight. Leaving a bed rail down, forgetting to wash hands. It's not just sloppy, it's a breach of a core ethical pillar.
Then you have beneficence, which is the active, positive counterpart. It's the duty to proactively do good and promote the patient's well-being. And that is coupled with justice, which is the strict obligation to distribute care fairly and equitably, entirely regardless of a patient's background, wealth, or social status.
And fidelity, loyalty, keeping your promises, which applies to the absolute smallest micro-interactions. If a nurse tells me, hey, I'm going to go check on another patient, but I will be back in exactly 15 minutes with your pain meds, they have just made an ethical vow.
In an environment where the patient is stripped of all their control, wearing a paper down, entirely dependent on strangers for survival, trust is the only currency that really matters. If you say 15 minutes and you come back in 45, you haven't just managed your time poorly. You have broken fidelity. You have fractured the trust required for healing.
Which brings us to the final pillar. And this is the one where I really genuinely struggle to understand how healthcare workers sleep at night. Veracity, the duty to tell the truth.
It is easily the most complicated of the six.
Because the truth in a hospital is highly regulated. Think about diagnostic test results. The text points out that legally, diagnosing a condition is completely outside of a nurse's scope of practice. Only the attending physician or provider can interpret and deliver those specific results.
Because delivering a complex diagnosis requires nuanced medical context to avoid giving inaccurate information or false hope.
I understand the logic, I really do. But put yourself in the patient's shoes, or the nurse's shoes for that matter. I am the patient. I've just had a biopsy to see if I have terminal cancer.
Yeah.
I am sitting in that sterile room, sweating, absolutely terrified. My nurse walks in to check my IV. I look them and I plead, please, is my scan back? What does it say? And the nurse knows the results are sitting right there in the electronic medical record system. What happens? Do they just lie to my face? How is that veracity?
It is an agonizing psychological and legal tightrope. If the nurse tells you the results, they are practicing medicine without a license. They could lose their job and their entire career. But if they say the results aren't back yet, when they know for a fact they are violating veracity by lying.
So how do they survive that moment?
They employ a very specific, almost tragic strategy. Many seasoned nurses will purposefully avoid opening that specific tab in the electronic chart. They see the notification pop up that the biopsy results have populated. But they actively choose not to click on it. They blind themselves to the data. That way, when you look up from your bed and beg for the results, they can look you squarely in the eye and say, I haven't seen the results yet. The doctor will need to go over them with you.
Wait, so it's technically true I haven't seen them because I intentionally covered my eyes.
Exactly. It preserves veracity in the strictest, most technical sense. But the emotional toll that takes on the provider is just immense. You are standing 3 feet away from a terrified family. You know the answer that will change their lives forever is sitting on a server. And you have to actively compartmentalize your own human empathy to maintain the rigid ethical and legal boundaries of your profession. It feels cold, it feels evasive, but it is literally the only way to navigate the system without breaking it.
It's protective ignorance. That is incredibly heavy. Okay, so we have the 6 pillars: autonomy, non-maleficence, beneficence, justice, fidelity, and veracity. But as complex as they are individually, the real chaos starts when these pillars crash into each other, because they rarely align perfectly.
Exactly. The core of ethical decision-making isn't choosing between right and wrong. That's easy. It's choosing between 2 competing rights or trying to find the least damaging path between 2 catastrophic wrongs.
And when a hospital floor descends into that kind of chaos, the professionals lean on overarching philosophical frameworks to make these impossible choices. The 2 massive heavyweights here are utilitarianism and deontology. And these aren't just dusty concepts from a college philosophy class. They are the actual engines driving life or death triage.
Let's start with utilitarianism, which is a consequentialist theory. In this framework, the inherent morality of an action doesn't matter. The only thing that matters is the outcome. The ultimate overriding goal is to achieve the greatest good for the greatest number of people. It is pure, unemotional, mathematical calculation.
And we saw this play out on a global scale recently with the distribution of the COVID-19 vaccine, specifically in nursing homes during the very early days of the rollout.
Right. And we should look at this strictly through an academic lens to understand the framework, removing any political hindsight.
Absolutely. Just to be clear to you listening, we're maintaining strict political impartiality here, framing it purely as an educational example of utilitarian logic from the text. So, if we transport ourselves back to 2020, there was a massive amount of uncertainty. We had a novel intervention. But a public health official operating under a utilitarian framework looks at the data, rampant, terrifying mortality rates in long-term care facilities. The utilitarian calculates that the potential unknown risks of a new vaccine are vastly outweighed by the massive, immediate benefit of saving the most highly vulnerable population. The individual risk is absorbed for the survival of the collective, the greatest good for the greatest number.
It is triage on a macro level. But then you step into the hospital room of a single patient, and utilitarianism can suddenly feel incredibly callous, which is why many providers operate under deontology.
Right, and deontology is the absolute opposite end of the spectrum.
Complete opposite. Deontology argues that an action is either right or wrong based on strict adherence to moral rules and duties, entirely regardless of the consequences. The outcome is completely irrelevant. The rule is everything.
Think about a doctor treating a patient who is screaming in severe, agonizing pain from a chronic condition. The patient is begging for relief, but this specific attending physician, point blank, refuses to prescribe a strong narcotic, like Dilaudid. Why? Because the doctor operates under a rigid deontological rule. These narcotics are highly addictive, they ruin lives, and prescribing them does long-term harm. They stick to that absolute rule, completely ignoring the immediate consequence that the human being sitting on the exam table right in front of them is suffering terribly.
For a deontologist, breaking the rule is a moral failure, even if breaking the rule would ease suffering in the short term. The duty to the principle outweighs the consequence of the pain.
Here's where it gets really interesting to me. It is wild to realize that as a patient, your experience of care, whether you get pain medication, whether you get a certain treatment, could vary wildly just depending on whether the doctor walking into your room that morning happens to be a utilitarian, calculating the greater good, or a deontologist rigidly following a rule book. It feels like a roll of the dice.
It does feel like a lottery, and it really begs the question, how do these highly educated professionals arrive at these fundamentally different worldviews? It actually comes down to psychological development. How do we evolve in our ethical reasoning?
Yes, the 3 levels of moral development from the text. This completely changed how I view authority.
It's a fascinating progression. So level 1 is pre-conventional morality. At this stage, decisions are driven entirely by a fear of punishment or a desire for reward. It is essentially self-preservation.
So a nurse at level 1 says, I ain't going to follow this doctor's order, even though I think it might be the wrong dose, purely because I do not want to get yelled at and I do not want to get fired. It has nothing to do with the patient's well-being. It's just survival.
Exactly. Then a person might mature into level 2 conventional morality. This is where choices are made based on a deep desire to conform to society, to please others, and to uphold the status quo.
This is the danger zone for the bad apple effect we talked about earlier, right? I'll ignore that safety protocol because none of the other nurses on the floor do it, and I want to fit in with the team. I want to be perceived as a team player. It's basically peer pressure masquerading as ethics.
That's perfectly stated. And finally, you have level 3 post-conventional morality. This is the highest, most difficult tier to reach and maintain. Here, decisions are based on universal, impartial principles of justice, human rights, and inherent dignity.
So a provider operating at level 3 will look at a hospital policy, realize the policy is fundamentally unjust to a marginalized patient, and they will break the rule to protect the patient, fully accepting that they might be fired for it. They're acting on a higher universal law.
But hospitals are massive bureaucracies. They know they cannot rely on every single exhausted staff member to constantly operate at a level of universal post-conventional justice. That is just an impossible standard for human nature. So when the situation is too complex or the staff is deadlocked between competing ethical pillars, the system takes over.
They bring in the heavy hitters, the ethics committee.
Right. These committees are the Supreme Court of the hospital. When a decision is truly impossible, it escalates to them. And what is vital to understand is the composition of these committees. If you only put surgeons and pharmacologists in a room to decide the fate of a human life, you will get a purely biological, mechanistic answer. You will miss the humanity.
Which is why the makeup of these committees is so diverse. You have doctors and nurses, yes, but you also have hospital administrators calculating resources. You have legal advisors looking at liability. You have social workers advocating for the family dynamics. And crucially, you have clergy or pastoral care representatives.
Because a human being is not just a collection of failing organs. They have spiritual needs, family structures, and cultural beliefs that must be weighed.
And these committees are forced to make the most horrifying, utilitarian versus deontological choices imaginable. Think back to the height of the pandemic. A hospital has 20 critically ill patients whose lungs are failing. But the hospital only has 5 ventilators left. Who gets them? The 80-year-old who arrived first. The 30-year-old who has a better statistical chance of survival.
It is pure, agonizing triage. The committee has to step in and absorb the moral injury of that decision, so the bedside nurse doesn't have to carry the weight of choosing who lives and who dies.
Okay, we spent a lot of time up in the philosophical clouds of committees and universal justice. Let's drag this down to the messy, high-speed reality of a modern hospital floor today. Because the landscape is shifting rapidly, and technology is creating brand-new, ethical nightmares that Florence Nightingale never had to worry about.
Modern medicine is besieged by new ethical battlegrounds. 3 of the most prominent are social media, the complexities of end-of-life care, and the widening gap in access to care.
I want to zero in on social media, because the speed at which a career can be destroyed by a smartphone is terrifying. There's this story from the lecture about a clinical group of nursing students at a children's hospital. They are young, they're excited, they've just finished a grueling clinical rotation. They're standing in the main lobby of the hospital, and they decide to take a celebratory group selfie.
A completely innocent, understandable impulse. They want to remember the day.
They snap the photo, they look at it, everyone is smiling, they post it to Facebook or Instagram, but what they didn't scrutinize was the background. Way in the back of the lobby, out of focus, was a child.
Not in a hospital gown, not hooked up to IVs, just a child in everyday clothes walking through the lobby.
The students didn't even register the kid, but the internet is a small panopticon of a world. The parent of that child happens to see this photo circulating online, and they immediately contact the hospital administration, absolutely furious. Why is my child in a photograph on your nursing student's social media? Why is the world being advertised that my child is seeking treatment at a pediatric hospital?
What's fascinating here is that the intent of the students was pure celebration. But the ethical and legal reality is that they committed a massive violation of patient privacy and confidentiality under IPA.
The fallout was immediate. The hospital didn't just reprimand the students. They implemented a sweeping, absolute ban on all campus photography. No pictures anywhere by anyone, period.
It perfectly illustrates how incredibly thin the ice is. You do not have to be malicious to be dangerous. A momentary lapse in spatial awareness, a background blur in a selfie, and you have compromised a family's privacy and altered the policy of an entire institution.
The speed of it is what's scary. But while social media is a modern minefield, the most wrenching, deeply human dilemmas still happen at the end of life, where the technology to keep a body alive outpaces the ethical consensus on whether we actually should.
The end-of-life scenarios are where the pillars of ethics most violently collide with the rigidity of the law.
Let's walk through a nightmare scenario. You have a patient who, a year ago, was completely competent. They sat down with a lawyer, they looked at their declining health, and they filled out an advance directive. They made their wishes legally, explicitly clear in writing: do not resuscitate. A DNR order. If my heart stops, do not crack my ribs doing CPR. Do not put a tube down my throat. Let me go peacefully.
That document is the ultimate expression of the patient's autonomy. It is their voice projected into the future.
But fast forward to today. That patient is now in the ICU. They are unresponsive. The monitors start blaring. Their heart is stopping. The medical team looks at the chart DNR. They step back to let nature take its course. But the patient's legally designated guardian, let's say it's their spouse of 50 years, is standing right there in the room. The spouse completely panics, the grief takes over, and they scream at the doctors, "Ignore the paper, do everything, save them, I am countermanding the order."
This is the exact moment where ethics and legal jurisdiction crash into each other at 100 miles an hour.
Who wins? As a provider standing over that bed with a defibrillator, who do you listen to? The past, written voice of the patient, or the present, screaming voice of the legal guardian who technically holds the power of attorney?
It is an agonizing paralysis. Ethically, the provider has a profound duty of fidelity to the patient's stated autonomy. To honor the DNR is to honor the patient's ultimate wish. But legally, the provider is staring at the immediate authority of the present guardian who has the legal right to alter decisions. If you attempt resuscitation, you violate the patient's autonomy and potentially commit battery against their written wishes. If you don't resuscitate, you risk the spouse suing you for wrongful death or negligence.
And meanwhile, the clock is literally ticking in seconds on a dying human being.
Yeah.
You don't have time to convene a 3-day ethics committee.
Exactly. These situations often force emergency consultations with hospital legal teams in the middle of the night, while the bedside team tries to rapidly de-escalate the panicked family member to honor the patient's original wishes. It is traumatic for everyone involved.
Which brings us to the dark side of this entire conversation. We've been talking a lot about what you should do ethically, how to navigate the gray areas. But let's cross the line. Let's talk about what happens when the gray area vanishes. You do the undeniably wrong thing, and the lawyers get involved. Let's talk about tort law.
This is where ethical failures metastasize into financially and professionally ruinous legal consequences.
We are diving into civil law, specifically torts. A tort, in the simplest terms, is a civil wrong committed by one person against another, where there is no contract involved. It's the basis for most lawsuits, and the law divides these into intentional and unintentional torts. Let's tackle the intentional ones first, because I think the general public, myself included, until I researched this, completely misunderstands these terms. Let's look at assault versus battery.
The public conception of these words is entirely skewed by television police procedurals.
Exactly. When I hear assault, I instantly picture a bar fight, someone getting punched in the face. But legally, in a clinical setting, assault has absolutely nothing to do with physical contact. Assault is just the threat. It is any intentional act that places a person in reasonable fear or apprehension of imminent physical harm or offensive contact.
The touching has not occurred. The crime is the creation of fear.
Go back to the scenario we started the show with. The exhausted nurse in the doorway. The confused patient trying to get out of bed. The nurse points a finger and says, "If you get out of that bed one more time, I'm going to tie you down."
That statement alone, in isolation, is the legal definition of assault. You've expressed an intention to use unauthorized force, and you have placed the patient in apprehension of being restrained.
Mind blown. You can be sued for assault without ever crossing the threshold of the room.
Now, battery is the actual execution. Battery is the unauthorized, intentional physical contact without the patient's consent.
And again, this doesn't have to look like a violent attack. It can look like routine care delivered forcefully. Imagine a patient who is perfectly competent. Let's say it's a female patient who explicitly states, "I am not comfortable with a male nurse giving me a bed bath. I refuse." But the floor is severely short-staffed. The male nurse is rushed, irritated, and says, "Look, I'm the only one on shift right now. You need to be clean, so we're just going to get this over with." And he proceeds to bathe the patient against her verbal objections.
In the nurse's mind, he might be acting out of beneficence providing hygiene. But legally, doing so against explicit, competent refusal is battery. It is an unconsented touching, and the hospital will absolutely not protect you if you do that.
Then we have false imprisonment.
Which is another term that conjures extreme imagery, like locking someone in a basement closet.
Right. But in a hospital, false imprisonment is usually about restraints. And not just leather straps on the wrists. It can be physical restraints, yes, but it can also be chemical restraints. Over-sedating a difficult, loud patient with Haldol, just to keep them quiet so the staff can get some work done. If you use restraints without an immediate documented medical emergency or without getting proper ongoing legal authorization from a physician, you are falsely imprisoning that person.
False imprisonment also heavily applies to the concept of a patient leaving against medical advice, or AMA.
This is a massive trap for providers. Let's say a patient comes into the ER with chest pain. They are completely sound of mind, but they get tired of waiting. They decide, "I'm leaving." They rip out their 5E and start walking toward the sliding glass doors. The instinct of the medical staff is to stop them, to say, "You can't leave. You might have a heart attack in the parking lot."
But if the patient is legally competent, you cannot physically block their path. You cannot hide their clothes. You cannot lock the doors.
You can warn them of the risks until you are blue in the face. But if you physically prevent a competent adult from leaving, you are committing false imprisonment. However, there's a monumental caveat to this that providers have to evaluate in a split second.
Competency is the hinge upon which the entire legal framework swings.
Yes. If a patient is severely dementia-stricken and they think they are walking out to catch a bus in 1985, or if a patient is actively suicidal and expressing intent to self-harm, In those specific scenarios, the law determines they are not legally competent to make decisions. If you let that confused or suicidal patient walk out the front door, you haven't respected their autonomy. You have failed your legal duty of care, and you will be held liable for whatever happens to them.
It requires the provider to act as a real-time legal judge of a stranger's cognitive state.
Moving on to quasi-intentional torts. Defamation of character. Slander, which is spoken defamation, versus libel, which is written. The criteria for this are incredibly strict. It has to be a false statement. It has to be communicated to a third party. It has to cause shame, ridicule, or negatively impact the person's reputation or ability to earn a living. And crucially, it has to be stated as a fact, not an opinion.
So if a nurse gets off a terrible shift, goes home, logs onto Facebook, and publishes false, specific allegations that destroy a colleague's professional reputation or compromises a patient's standing in the community, that is libel. It is highly actionable in civil court.
So the intentional torts require you to actively do something wrong. The unintentional torts, negligence, and malpractice are where the vast majority of healthcare workers find themselves in terrifying trouble. This is failing to act as a reasonable and prudent professional would in the same scenario. And the way the law enforces this is through case law.
Case law is the evolutionary mechanism of the legal system. When a completely novel, unprecedented event occurs, the courts have to figure out how to handle it. The outcome of that specific trial then sets the precedent, the template, for every single similar event that happens nationwide thereafter.
And this brings us to one of the most chilling examples we found in the source material, the Vanderbilt University Medical Center case. This sent absolute shockwaves through the entire medical community. A nurse was assigned to take a patient down for a routine PE scan. The patient was claustrophobic, so the doctor ordered a standard, mild sedative Versed. The nurse went to the automated medication dispensing cabinet, but instead of pulling Versed, through a series of tragic system overrides and manual errors, she accidentally pulled vecuronium,
which is a powerful paralytic agent used to stop patients from moving during surgery or intubation.
She'd administered the paralytic, thinking it was the sedative. The patient was placed into the scanner. Because they were paralyzed, they stopped breathing, they could not call for help, and they died. It is a horrifying, catastrophic medical error, a clear-cut case of malpractice. But what made this case historically terrifying is what the prosecutor did next.
The state did not just let this be a civil malpractice lawsuit handled by insurance companies and medical boards.
No, they charged the nurse with criminal homicide, reckless homicide, murder.
It was a watershed moment in modern medicine. Historically, clinical errors, even fatal ones, were treated as civil matters, a failure of the system or unintentional negligence. By bringing criminal charges, the state signaled that an unintentional mistake at work, a failure to read a vial correctly in a rushed environment, could land a healthcare worker in state prison.
While she was eventually convicted of a lesser charge, the fact that the criminal charges were brought and successfully prosecuted completely reshaped the landscape of legal risk. It became the case law that every single nursing and medical student now studies. It is the ghost haunting every medication cabinet.
And we are seeing these tectonic shifts in liability continue. Look at the recent case in Florida from the text. A nursing student, during their clinical rotation, made an error resulting in a patient falling and tragically passing away. The family is not just suing the hospital, they are suing the nursing school itself.
The implication is massive. If a school can be held financially liable for the actions of a student who is still learning, how do you educate? Do you just keep students in simulation labs on plastic dummies forever? If the school loses, the case law will dictate how the next generation of professionals is allowed to be trained.
Okay, given all these terrifying traps, malpractice, criminal homicide for a med error, assault for making a verbal threat, what are the specific federal statutes that dictate daily practice? How does a frontline professional actually protect themselves from ending up in a courtroom?
We have to look at the massive federal mandates first, starting with EMTALA, the Emergency Medical Treatment and Active Labor Act. This is the ultimate safety net law in America.
It was designed to prevent patient dumping.
Exactly. Before EMTAL, if a person without health insurance showed up at a private for-profit hospital having a heart attack, the hospitals could literally say, "You can't pay, we aren't treating you." Put them back in the ambulance and take them to the county hospital across town. And people died in transit.
EMTALA made that illegal. It states that if any person seeks emergency care at a Medicare participating hospital, which is virtually all of them, the hospital is federally mandated to provide a medical screening exam and stabilize the emergency medical condition. It does not matter if they're homeless, it does not matter if they are undocumented, it does not matter if they have $0 to their name.
You cannot ask for their wallet before you stop the bleeding.
Yeah.
You must stabilize them. Period.
Then you have mandatory reporting laws, which represent a fascinating override of patient privacy.
We hold HAPER up as this impenetrable fortress of confidentiality. But mandatory reporting blows a hole right through it. If a healthcare worker is treating a patient and suspects child abuse, elder abuse, intimate partner violence in certain states, or encounters specific highly infectious diseases like tuberculosis, they are legally obligated by the state to report it to authorities.
The duty to protect the vulnerable population or the public health explicitly overrides the individual patient's right to privacy.
And you can't just say, well, I don't want to get involved, I'm just here to fix the broken arm. If you suspect abuse and fail to report it, you become criminally liable. You can be charged with a misdemeanor, stripped of your license, and fired.
Now, let's look internally at the culture of compliance, specifically regarding unprofessional conduct. Because there are systemic pressures that push otherwise ethical people into dangerous territory.
Falsifying medical records. This is an incredibly uncomfortable open secret in hospital culture. We've established the medical record is a legal document. It is subpoenaed in court, so you would think it is sacrosanct. But when you ask seasoned nurses what the most commonly falsified entry in a medical chart is, the answer is almost universally the same: respirations.
The patient's breathing rate.
To properly take a respiratory rate, you are supposed to stand at the bedside, look at the patient's chest, and count the rise and fall for 1 full minute. But on a floor where a nurse has 6 high-acuity patients, alarms are ringing, and medications are late, taking a full 60 seconds just to stare at a chest feels like an impossible luxury.
The systemic pressure for speed overtakes the ethical duty of accuracy.
So what happens? They glance at the patient, see they're breathing normally, and just type 16 or 18 into the computer because that's a normal, healthy range. They guess. They move on to the next crisis.
But consider the legal consequence. If you document a respiratory rate of 16 at 2.0 p.m. and at 2.05 p.m., the patient suffers a massive respiratory arrest and codes MAC.
The lawyers will pull the chart. They will look at your entry and say, you documented their breathing was perfectly normal 5 minutes before they collapsed. Either you are completely incompetent at assessing a patient, or you lied on a legal document. It is entirely indefensible in court. You falsified a record to save 60 seconds, and it will cost you your license.
Now, what happens when you take the healthcare worker out of the hospital? What if they are entirely off the clock grabbing dinner and an emergency happens?
This is the domain of Good Samaritan laws. And again, television has completely warped our understanding of this. The general idea is that Good Samaritan laws exist to protect citizens who step in to provide emergency care in good faith from being sued if things go wrong.
It is meant to encourage intervention rather than hesitation out of fear of liability.
But there are massive limits to this protection for medical professionals. The most hilarious but dead serious example is the TV steak knife track.
We have all seen this scene in a movie or a medical drama.
Oh, yeah. Someone is choking in a crowded restaurant, the Heimlich isn't working, their airway is completely closed, the hero doctor looks around, grabs a dirty steak knife from the table, slices a hole in the person's throat, and jams a hollowed-out ballpoint pen into the trachea to let them breathe. Everyone claps. Life saved.
But if a registered nurse or a general practitioner attempts that in real life,
it is an absolute legal disaster. Because the crux of the Good Samaritan law is that it only protects you if you act within the scope of your competent training. If you are an ER trauma surgeon who does emergency cricothyrotomies every Tuesday, you might be protected. But if you are a floor nurse or a physical therapist, you are absolutely not trained or authorized to perform surgical incisions in a restaurant.
doing a procedure you learned from watching Grey's Anatomy is not practicing in a reasonably prudent, competent manner. You have exceeded your training, and if you paralyze or kill that person, the Good Samaritan law will completely abandon you. You will be sued and you will lose.
Furthermore, the law is strict about abandonment. Let's say you do perform basic CPR on a sidewalk. You get a pulse back, the person starts breathing. You cannot just wipe your hands, say, my work here is done, and walk away to finish your errands.
By initiating care, you have temporarily assumed a legal duty of care for that vulnerable person.
If you leave them alone on the sidewalk and their heart stops again, you are guilty of abandonment. You must physically remain with that patient until you can transfer care to an equally or more competent professional. You stay until the paramedics arrive and take over.
Okay, so bringing it back inside the walls of the hospital. How do providers survive the daily friction with their own colleagues? The rulebook gives very blunt advice about self-preservation.
The CYA strategy. Cover your well, cover your butt. It is the grim reality of defensive medicine.
It is the acknowledgement that the system will protect itself before it protects you.
Let's say you are working and you see another nurse making a dangerous error. They are drawing up a syringe of insulin, and you realize they have calculated double the lethal dose. You stop them. You say, hey, check your math. That's way too much. They fix it. Crisis averted. In a normal workplace, that's the end of it.
But in a hospital, a verbal warning in the hallway is legally meaningless. It never happened.
The institutional advice is that you must immediately create an undeniable paper trail. You have to follow up that hallway conversation with an official company email. Dear colleague, per our conversation at the MedCard today at 3 p.m., I am formally expressing my concern regarding the insulin dosage miscalculation. Why do you have to be so bureaucratic and cold about it?
Because of the instinct for self-preservation. If that nurse goes on to actually administer a lethal dose to a patient an hour later, there will be a massive, devastating investigation. The hospital risk managers and the lawyers will descend.
And if they interview that nurse and the nurse realizes they're facing prison time, human nature kicks in. The source of material is brutally honest about this. People will absolutely throw you under the bus to save their own license. The nurse might say, I didn't know what was wrong, and my colleague saw me draw it up and didn't say anything.
If it is your word against theirs, the person without the documentation loses. You become an accessory to the negligence. The email is your shield.
Which leads to the final, somewhat depressing piece of advice given to frontline workers. It really paints a picture of how terrified the workforce is, the absolute necessity of carrying personal malpractice insurance.
So, what does this all mean for the frontline worker? Are they just paralyzed by fear of lawsuits?
Most people assume that if you work for a hospital, the hospital's massive legal team will defend you if something goes wrong. But this is exactly why individual nurses buy their own policies.
And they will defend you, right up until defending you threatens the hospital's reputation or bottom line. The moment your actions become a liability to the corporation, their lawyers will argue that you were operating outside of hospital policy, thereby voiding their responsibility to cover you. You are suddenly standing alone against a multi-million-dollar lawsuit.
Right, and the source specifically mentions NSO insurance for around $168 a year.
Yep.
It's affordable. But the philosophical implication is profound and, frankly, grim. It highlights a healthcare system where individual professionals feel they must legally armor themselves, not just against the litigious public, but against the very employers who might scapegoat them when systemic administrative failures occur. You are paying out of pocket to ensure you have a lawyer whose only client is you.
It is a profound lack of trust in the institutional safety net. It explains the burnout, the moral injury, and the mass exodus we see in healthcare professions.
It really does. It is an entirely different lens through which to view the person walking into your hospital room to check your blood pressure. So, to recap the massive journey we've taken today, we started with the quiet, private, internal compass of our personal morals, what we believe to be right in our souls. We watched how those morals are forcibly subordinated to the rigid traffic law pillars of professional ethics, autonomy, beneficence, the agonizing complexities of veracity. We watched those pillars clash in utilitarian triage and deontological rules. And finally, we ended up knee-deep in the severe putative realities of tort law, case precedents, and the desperate need for defensive paper trails.
It is a gauntlet. It is a miracle anyone chooses to do the job.
It truly is. And I genuinely hope that for you listening, the next time you find yourself in a hospital, whether you are seeking care for yourself or sitting vigil for a loved one, you remember this hidden architecture. You aren't just looking at caregivers and scrubs dispensing medicine. You are looking at highly trained, deeply burdened ethical agents. They are actively navigating a literal minefield of federal laws, state practice acts, corporate liabilities, and impossible moral dilemmas. Sometimes they're balancing all of that just to bring you a cup of water or to look you in the eye and navigate the agonizing truth of your scan results.
It is an immense, invisible burden that they carry silently every single shift. But as you wrap up this exploration, I want to leave you with a final thought to ponder. A thought that looks over the horizon, building on these frameworks of how decisions are made. We discussed how utilitarianism and deontology clash in human minds today. But as hospitals increasingly integrate artificial intelligence to manage resource allocation and triage, will these machines operate purely on utilitarian math, sacrificing the individual for the group? And if so, will the human nurse's ethics of care be the only legal and moral defense the patient has left against the algorithm?
Wow. If the algorithm says no, who is left to say yes? That is a heavy, monumental question for the future of our health. Thank you so much for joining us on this deep dive into the hidden rulebook of medicine. Stay insanely curious, keep asking questions, and we will see you next time.